Okay, we're going to try to get started and get back on time if we can. So it's my pleasure to introduce Kevin Cavanaugh, who is the founder and board chairman of HealthWatch USA, a nonprofit patient advocacy and healthcare policy research organization. And I just realized he's an associate editor of the Journal of Patient Safety. So Kevin, welcome.
Well, thank you very much. I'd like to talk to you today regarding preventable hospital mortality. And if you take home nothing else from this lecture, please remember these 2 points. One is that we know far too little about this subject. And the other is that what we do know is that preventable hospital mortality occurs far too often. No one is really counting. The medical profession was largely silent after the 1999 Institute of Medicine's report, which estimated that there were between 44,000 and 98,000 preventable hospital deaths each year. In 2013, a NASA scientist, Dr. John James, a father who lost his child to medical error, published an updated estimate in the Journal of Patient Safety. This estimate is both widely criticized and praised, but I think we need to take note that most importantly, it took a patient advocate to refocus medicine on this problem. Dr. James estimated that there were between 210,000 and 440,000 preventable deaths each year. He based this on 4 studies which used the global trigger tool to identify adverse events and weighted these studies based upon the size of their N. In 2 of these studies, preventability, however, was not determined. And in one study that didn't determine preventability, it was stated that 100% of the deaths from adverse events should be considered preventable, and that was the figure that was used. The Leapfrog group in 2016 estimated that there were 206,000 preventable deaths each year. They used a total of 16 publicly reported metrics to establish this estimate. These included methicillin-resistant Staph aureus, Clostridium difficile, and other healthcare-associated infections, 3 healthcare-associated conditions, and 7 patient safety indicators. McCary and Daniel in 2016 estimated in BMJ Open that there were 251,000 preventable hospital deaths each year. They based this on 4 studies, which they weighted equally, and they also made the observation that this high of a rate would make preventable hospital deaths the 3rd leading cause of death in the United States. Myself and a number of patient advocates published an estimate in the Journal of Patient Safety of 163,000 preventable deaths each year. We also reviewed the literature on this subject. We based our estimate on 2 studies which determined the global trigger tool and determined preventability, and we weighted these studies based upon the size of their N. Now, all of these studies used vastly different methodologies. There was some overlap with the data sets, but they all came up with numbers which are unacceptably far too high, over 100,000 preventable hospital deaths every year. The reaction to these publications was surprising. Dr. John James's article spurred a spokesperson from the American Hospital Association to state that they did not agree with using the global trigger tool to determine and detect preventable hospital deaths, and that they were going to stick with the Institute of Medicine's figure of 98,000 preventable hospital deaths each year. Now, I found this to be pretty telling and surprising, since in my view, this was a hospital spokesperson from a major hospital organization that essentially stated preventable hospital deaths were far too common, being 98,000 deaths per year, and there was no appreciable improvement in over a decade. The main reaction that I have heard to these publications has not been a renewed commitment to invest more resources in patient safety, but instead, it's been the generation of a myriad of excuses justifying the status quo. Since its inception in the mid-1980s, the Anesthesia Patient Foundation has promoted innovative techniques for the prevention of adverse events and the prevention of deaths. And in part, they have emulated and adopted techniques of the aviation industry. So what I'd like to do today is to look at some of these excuses I have heard and relate to what goes on in the aviation industry. One of the most common is that, well, causality wasn't proven. The error occurred, but it didn't cause the fatal event. Well, in the airline industry, all factors are found and corrected. Proving causality is not required. Severe events are not mitigated, but they are dealt with seriously and corrected. This is also true in other fields of science, such as in geology and paleontology. In this month's issue of The Atlantic, there's an excellent article called "The Nastiest Feud in Science." And this is over what caused the extinction of the dinosaurs. Was it caused by volcanoes, or was it caused by an asteroid impact? Both events occurred. Both events were extinction-leveled events. So I have to ask, why does one event have to be responsible? Why can't they both be responsible? Why don't we concentrate on the event and don't worry so much about the outcome? I will hear the excuse that it's the patient's fault because of poor life choices. The patient smoked, the patient drank, the patient was overweight. But if a traveler wishes to travel between Washington, D.C. and New York City and chooses to go by train, and that train has a fatal preventable accident, is his death discounted because he made the life choice of traveling by train instead of the safer mode of transportation, an airplane? No, it's not risk adjusted. It's the event which is concentrated on, and that is what is important, because if you don't correct the event, the fatal and tragic outcome will be repeated. I will also hear the excuse she was very sick and old and had only a short time to live. And this just makes I can't tell you how often I've heard this, and it's not a good excuse. And again, in a fatal airline crash, you never hear the airline company discounting the deaths because some of the passengers were old and frail and would have died soon anyways. No, they concentrate on the error. That is what is important. I will hear that it's a very hard and complex case. Again, in the transportation industry, some of the travelers fly long legs of travel with multiple takeoffs and landings and have complex itineraries, which place them at higher risk for an adverse event. But they're not risk adjusted downward when a fatal airline crash occurs. They focus on the event. So one of the important messages of this talk is that preventable errors must and should be separated from the context of the patient. It doesn't matter what the status of the patient is. We need to concentrate on the error, or that error will repeat itself and may in the future have a more tragic outcome. So that is what is important. I will hear the excuse that, well, European and Canadian studies have shown that our medical profession is doing quite well in preventing errors. In fact, that was a major theme at a keynote speech at the National Patient Safety Foundation. Well, this is like comparing apples and oranges. The United States healthcare system is fragmented. What goes on in one hospital doesn't necessarily go on in another hospital, and these type of extrapolations are not valid. In the airline industry, we do not use data from foreign carriers and airlines to measure the safety record of the United States airline system. Full disclosure is extremely important. In the airline industry, all events are disclosed which cause harm. If you park your car on the side of the road and someone hits it, you would expect that to be fully disclosed, that the person would leave his name and address. Hit and run accidents are not tolerated. They are illegal. Only in medicine is this debated. I've read an article on the ethical dilemmas of full disclosure. In no other area in our society is that behavior tolerated. Now, the numbers I quoted may well be too low. Who commits the error is important. If a fatality is caused because of a government approval of an unsafe drug and device, that's oftentimes wouldn't be counted as a hospital fatality. Diagnostic errors have been contributory factors in up to 5% of hospital deaths. But again, those are not counted. And 90% of adverse events can be missed in studies which base their estimates solely on volunteer reporting or patient safety indicators. We can and we must do better. The Leapfrog Group estimates that 33,000 lives would be saved if all hospitals performed at a similar level as their highest group of functioning hospitals. In our healthcare system, we have little standardization. Just this July, AHRQ took down the National Guideline Clearinghouse, and I feel that this was a huge step backwards in patient safety. Our healthcare system has an aversion to checklists. Too many hospitals have a poor working environment, and too many hospitals have understaffing of nurses. If you look at the causes of adverse events, the two major causes that are most frequent are pressure ulcers, accounting for 32% of adverse events, and drug reactions, adverse event reactions, which account for 30%. And believe me, anesthesia falls into the category where that piece of the pie is extremely important. Now, detractors will state that there are a little over 700,000 deaths each year in hospitals, so how can the numbers be that high? Well, if you don't believe the number of 200,000, what about the low range of the Institute of Medicine's figure of 44,000 preventable deaths each year? Is that too many preventable deaths? Or how about 10,000 or 5,000? What would happen to an airline company which had 5 preventable deaths in a year and refused to acknowledge them or change practices? I would predict that they would be out of business. So I'd like to close and leave you with this old ancient Chinese proverb, is that if we do not change our direction, we are likely to end up where we are headed. Thank you. Oh, I've got one. Can I do one little footnote? I've got maybe a little bit of time left. Relating to the MAUDE database and FDA reporting, we're currently doing our group a study on that. We duplicated the MAUDE database. And one of the interesting findings we found is that physicians make 17.5% of all reports to the FDA, but they're almost always made through the manufacturers. Only 0.09% of physicians report a problem directly to the FDA. 96% of the reports that the FDA receives are from the manufacturer. So if a physician or a patient reports to the manufacturer, patients may do this because of wanting to claim a warranty on the device. You're not sure how that report's going to be redacted when it's passed on. And I really would encourage physicians to get on MedWatch and report directly to the FDA because it's a very, very low number at this point. Thank you.
Thank you, Kevin. Not sure if I want to fly or take a train. Okay, our next speaker is Joyce Ware, Vice President or Vice Chair for Quality and Safety for the Department of Anesthesia at the University of Minnesota. Actually, Mark, you should have introduced your colleague here. But anyway, welcome.
Well, he's at the Mayo. Don't you mean my competitor?
Your competitor?
Our
You're right.
collaborators.
We just think of everything in Minnesota as
Minnesota's
being
all
at the
one
Mayo
because we're all
Clinic.
frozen together, right? Well, thank you to the organizers for being invited to talk medication. Oh, I have to stand by this. Yeah, I know exactly. I have such a loud voice. Most people tell me to quiet down. So this I do have potentially some conflicts of interest, but really I'm not making any money on those, so I think I'm free and clear. And I received this invitation from David because of a project I was involved with about 9 years ago. The Society of Cardiovascular Anesthesiologists was starting a foundation and wanted a national project to hopefully drive fundraising. And Bruce Spies came up with the concept of FOCUS, which was flawless, operative, cardiovascular, unified systems, i.e. teamwork in the cardiac operating room. And we put out a request for proposals, and Peter Pronovost, being the genius that he is, turned in a proposal titled Lens. Was going to focus with the lens, which was locating errors through network surveillance. And the concept there is that at this point in healthcare, we have to be a team, and we have to expand how we think about errors and how we think about solutions. We can't just be thinking ourselves as physicians, how are we going to fix things, or even just nurses and pharmacists. We have to expand even further. We need to have our human factors engineers heavily involved in looking at the devices that we interact with and how can we make it safer. Industrial psychology and applied organizational psychology. We all know James Reason and how humans make errors. How many of us can say what are the 5 ways that teams make errors? And yet it usually is a team error along the way. So I'm going to try and bring that sort of framework to medication safety. And this, of course, is the APSF framework that came out of, was it the first one, Mark? I think it was the first one in 2009, published in 2010. And you could see that already a lot of the things were there. Every anesthetizing location should have a mechanism tied to clearly identify medications before drawing up, preferably barcoding 10 years ago. Mandatory safety education, all of these things. And then automated dispensing machines. A lot of us have, the first part of it, we have the dispensing machines, we have the Pyxis. Is it linked to the rest of the pharmacy? And then culture. Culture is so critically important. Of course, that is what Peter was trying to bring in with that entire Lens project, that we have a culture of collaboration. So technology for network surveillance is pretty straightforward and actually is really impressive, I think, at this point in most of the hospital. Our computerized provider order entry systems, our automated dispensing cabinets, our barcode administration mechanisms, our IT guys, phenomenal support systems, laboratory and pharmacists are all linked. And I think most of us know, or maybe we just take it for granted now, we put an order in and we maybe get a drug alert, maybe we get a warning, but in the background there's a huge amount that is going on and it's tremendously networked. This is my little scheme of how things are potentially networked. So we put an order in, it goes into the electronic health record. There are parts of that, here's our decision support, they instantly check allergies, drug interactions. The EMR can also check with laboratory so that you could potentially get this when you put it in. So that decision support went and looked, what is the patient's creatinine, and gives you a warning, we need to adjust the dose for you. So a lot of decision support, I think we're just at the beginning of decision support. But it goes into, the order goes in there, then the pharmacist double checks it, checks the doses. Is this appropriate? Then they release it, the nurse sees it. Our EMR, of course, has the patient ID, printed out a label. The nurse goes to the, nurse goes to the Pyxis, puts in the patient's name, gets out the drug, takes it back to the patient, barcodes. When she scans that, barcodes the medication, barcodes the patient, the electronic record or the IT background checks to make sure that that's all lining up, and if not, you get a warning. Our Pyxis machines also, of course, will tell central supply what the inventory is and may even be automated to the supply chain. So that's what happens in the vast majority of the hospital. I work a lot in the pre-op clinic. I have all of that decision support behind me when I write an order for a patient. So that was my simple little scheme. This is what it really begins to look like. So you can see down at the bottom it says EHR connectivity map, and I guarantee you that's just the very simplest scheme. So what does that look like in the operating room? Crickets, right? Do we hear crickets? So we do have our anesthesia information machine, system, and certainly our AIMS allows us to get into the record, or we're in the record, so we can then go check ourselves the allergies, drug reactions, all of those things, but it doesn't automatically tell us. We have to think to go and check the creatinine before we give the vancomycin, because we never put an order in for vancomycin. We just pick it up out of the drawer and give it. What if our Pyxis machine, if we picked up vancomycin, knew who the patient was and could give us an alert? And we don't have, does anybody here have decision support in the operating room? So we have a few. We really don't have much in our operating rooms at the University of Michigan at this point. And our Pyxis machines, I guarantee you our Pyxis machines are networked so we can collect billing, but it's not networked to give us drug alerts. Michigan, do you guys have some drug alerts with your Pyxis machines? Yep. Or I should say ADCs, right? They're sort of few and far between, so that we in the operating room, we anesthesiologists stand in our little island, in our little cockpit, really not networked to very many places at all. It's us, we're the captain of the ship, we're putting the sails up, we're taking them down, we're adjusting the trim, we're doing it pretty much all by ourselves. And those systems are out there. Safer Sleep was one that Ellen Mary put together, published a very large trial on it in 2010, and that consisted of really an integrated, networked, if you will, system, barcoded color labels, touchscreen computer. When you barcode the syringe, you get a splash screen with the name and an auditory input, what the medication is. Codonics is very much the same. Codonics added the printer so that you pick up the vial, scan it. As you're drawing it up, the printer's printing the label. You put the label on the syringe. And then when you go to administer the drug, you barcode again, and a dose entry screen pops up. The most difficult thing of both of these, and you'll see it in Andy, I think Andy's has it in the paper that's going to be coming out. One of the difficulties is that physicians just didn't barcode. They just wouldn't sweep. When it was done, Safer Sleep has been published, 2 very large trials, one in real life, one in simulation, and it definitely cuts medication errors. But again, the biggest obstacle was physicians not wanting to barcode. We do have some other technologies. We do have smart pumps, and I think that's pretty widespread at this point. Standardized drug libraries, we have guardrails, and coming fairly soon, I think, are Bluetooth pumps that interface with the electronic record. So if you have an infusion pump in the anesthesia or in the operating room, your computer there will recognize which pump you have, and when you want to order the pump to do something, you do it on your computer screen. So instead of trying to, and those of us that are older, get all the numbers and the decimal points right, you're going to have an order entry screen that looks like our typical order entry. So that, again, offers, I think, many more opportunities for network surveillance and even to begin to pull in our decision support. But there's also, that's the technology side of it, there's also the tremendous human factors involvement. And as I said, we physicians, especially in the operating room, tend to see ourselves as isolated, but we have got to pull in all of the members in the operating room and think of ourselves more as a team. We just had a medication error, a 9-year-old girl having a total pancreatectomy for chronic pancreatitis. And when we infuse the auto-islet cells, we always give heparin because you can clot the portal vein. 10-fold error in the heparin dose. The individual, the provider who drew the heparin up, didn't ask anybody to check the calculation with her, didn't ask the nurse to come watch me draw this up. We got lucky. There was no significant harm, but a 10-fold dose is just huge. But we are not taking advantage necessarily of our teammates in the operating room. Certainly, I think all of us adore our pharmacists and count on them tremendously. We have to be even more, involve them even more in our daily lives. IT, anesthesia seems to be down at the bottom end. When I turn a ticket in for something we'd like to change in the operating room, it's way down the list. And then human factors engineers. How many of you have a human factors engineer in your hospital to help drive, help drive choices about which anesthesia machine are you going to buy? What are the ergonomics? How are you going to interact with it? They think in a different way than we do and can really be helpful. So we are moving away from the autonomous physician role and really have to be multidisciplinary every single day. We have put together quite a few enhanced recovery after surgery programs, and our order set managers have been tremendously helpful in helping us think about, if the order set looks like this, what is the downstream effect of that? So working very closely together. And it's not just on order sets, incident review, root cause analyses, developing our policies and procedures, and then even in our education and training. We have people who are great at educating and training and pulling them in. We've just begun to use our university school of education to help us educate and train. And my personal thing, get more human factors engineers in to help us do this. Thank you.
Okay. Hey, Julie. Hi, Julie. How are you? So our next speaker is where's your name on here? Huh? Did it even make it? Oh, there, you're on the other page. Okay, it's Julie Boynton. And I had not met Julie, but I was talking to the folks at the Institute for Safe Medication Practices, and they said, oh, Julie did a fellowship while she was working on her Doctor of Nursing and looking at anesthesia errors. And so I had the chance to chat and just had the chance to meet here. So Julie, welcome, and we're really looking forward to your paper here.
Okay, so I spent most of my doctorate in nursing practice work studying the factors that contribute to medication errors. And I don't have any conflict of interest. My views are my own. So what you learn very quickly is we all have a story, and we've heard some of those stories today, but we're still relying on a culture of self-reporting, and we have different reporting systems that we have in our different facilities, But ultimately, if you make the error, you have to own up to it. And so how many errors are being made that we don't know about right now? So does the literature really support all the stories that are there to tell? Because I'm here to tell you that every one of us in this room has a story. So what are the contributing factors? One of the hardest parts to go back and look at all the literature and see what the contributing factors was we don't have any kind of standardized taxonomy for that. But as we go through it, I want you to look and see if there's really a trend in all of it, and I think there probably really is. It doesn't matter what the patient's characteristics are. Sicker doesn't make them more prone to error. Healthy doesn't make them more prone to error. The only thing in one study was that females were more likely by 1% to have more error than males, but nothing that was of significance. Environmental factors. Changing the provider multiple times. And that would be either through the case or think about the system that we operate in. The patient comes from the office or the emergency room or the floor to the pre-op area, and then they come and interview with several people, and they go to the operating room. And from the operating room, there's several anesthesia providers usually, and then they go to the recovery room, and they get to the recovery room, and then they either go to the floor or they go home. We've already increased the number of providers, nursing, anesthesia, surgeons, lots of people to interact with. Fragmentation of care kind of incorporates the same thing, but it could be that maybe somebody comes in to give a break for 5 or 10 minutes. Is there something that's lost in there? The length of the surgery, the longer the surgery is, the more apt you are to have an error. And transfers of care, that's back to different areas moving forward. Types of error. This is really described differently in the literature, and it just depended on who was describing it. The most common error is wrong dose or incorrect dose. It's described both ways. Substitution, or it could also be picking up the wrong syringe, is an error, or omission, forgetting to give something. Maybe you're about to go on pump and you forgot to give the heparin. That's a reported error. Causes. Communication. Are we very clear in what we tell each other? Maybe it's not anesthesia providers' communication to each other. Maybe the patient forgot to tell us something that was significantly important to their care. Or the nurse isn't communicating correctly with the surgeon or the anesthesia provider, and you miss something that way. We're all accountable in the operating room evaluation. Knowledge deficit. Are there people who are afraid because of the culture that we have to say, I don't know, or I haven't encountered that medication before, and so they just give what they think they're supposed to give? That causes errors. Labeling. Labeling is package labeling. It's labeling of syringes. It's how people decide to do it. Human factors. Fatigue was huge, actually, and a lot of people reported. So if you go back and look, if you are texting and driving, you have a blood alcohol level of 0.08. It's the equivalent to a blood alcohol level of 0.08. If you have been doing anesthesia for 12 hours, you start to make errors. At 18 hours, that increases significantly. And by 24 hours, it's the equivalent to having a blood alcohol level of 0.1. That's worse than texting and driving. So should we be doing super long shifts? And then vigilance. Vigilance is about paying super detailed attention, and we all know that's becoming more of an issue. So is this a problem of normalization of deviance? Have we slowly but surely over the last period of time been able to hide behind the OR doors, do as we wished, and even though there have been suggestions to change, we continue to do it the same way we've always done it? And it's just kind of accepted that, oh, well, that's anesthesia, and they just do it that way. Does that make it right? Not necessarily. So here's some examples. I went through some operating rooms, and these are things that we see and kind of scary. This is, well, I always put my rock in a 5 cc syringe, and I put my lidocaine in a 3 cc syringe, so I know what's in there, and it's okay. And this is, well, I labeled it. This added some color. This is a never, but we still see a lot. This is, Jayco would be horrified. Here's the standardization and the pre-filled syringes. We're seeing a transition to more of this. This is a little more ideal. And here's the label, a printed label that you could actually read, and more progress. So my question is, are we making errors? And everybody in this room would say, yes, we're making errors. But do the providers in the operating room truly believe that they're making errors? If I accidentally pick up the stick of rocuronium and give the entire stick, but I can give Sugamidex and reverse it very quickly now, did I make an error? Is that a reportable event? Not everybody would agree with that. If I give propofol and give the whole stick and the patient's blood pressure becomes 50, but I can give phenylephrine and ephedrine and get out of it pretty quick, did I make an error? Not everybody would agree with that. So how is error defined? How do we as a profession define medication errors? And what is our expectation in practice? And how do we get people on board in the culture? One, to report it, and two, to know that it's okay that we need to work together to improve the process. So everybody has a bunch of these pictures. These are all vials that look the same. Adenosine instead of Zofran, that would cause your heart to skip a couple beats. Epi instead of Toradol. Hydralazine instead of Zofran. We've all got these pictures. But I want to tell you a story. The labels on the left are the colored labels that we have in a label printer that we use all the time. However, one week we ran out of colored labels, and I thought, no big deal, I'll switch to white. The color will be here in a couple of days. It didn't take long, and everybody started saying, Julie, where are the colored labels? I don't like these white labels. What's wrong with them? And I said, I listened. I said, the color ones are on the way. I'm aware. It's okay. But then I started asking, why don't you like these white labels? And I had numerous anesthesia providers tell me, Julie, it's because I have to read the label. So I ask you, it's funny, but it's not. I ask you, are we giving rainbow anesthesia? And are we truly engaged in what we're doing? Or have we moved from actively participating in the anesthesia process to passively giving anesthesia because we know it's safe most of the time? And if you looked at all of the trend and all those factors, is it really the human? Is the human the problem in the process? We have these issues as they're classified: communication, stress, awareness, attention, memory. How many ORs do you walk in and have an iPad or a cell phone? It used to be crossword puzzles and magazines. It's just changed to the technology. So is it the human, and what could we do to address that? Is it to remove the human from the process? What if we use the barcoding on the labels and scanned it, and it could be scanned to the EHR and scanned to the smart pumps, and the smart pumps communicated with the EHR, and it would, using the EHR and the smart pumps as a secondary verification, could take the human out of part of the process. If we take the human out of some of the manual process and use the human for clinical decision making, the human will have more time to think about the critical decisions that need to be made and spend less time passively giving anesthesia and move back to actively giving anesthesia care. Thank you.
Okay, our next speaker will be talking about drug concentration standardization. Elizabeth Rebello, from Associate Professor, Department of Anesthesia and Perioperative Medicine, University of Texas, MD Anderson. Elizabeth. Welcome.
Thank you.
Okay, thank you. Here's your clicker.
Good afternoon. It's a pleasure and a privilege to be here. speaking with such a diverse audience today in terms of practice setting, types, and spectrum. I will be speaking on the topic of drug concentration standardization. I'd like to begin by stating that I have nothing financially to disclose. However, as a practicing anesthesiologist and a pharmacist, I've worn more than one hat over the course of my career, and it's been a pleasure being able to serve on both sides, and I've really been able to see the benefits from having collegial and collaborative relationships in moving this dial forward. So each day, thousands of patients expect the medications administered to them to be safe and intended for their underlying disease. However, medication errors continue to occur. As Julie discussed, there are several causes and types of medication errors, but I'm going to focus today just on one particular one, and that is the variance in medication concentrations. There are several factors that contribute to this variance. Distractions, which has been discussed before, drug shortages, which Trish Meyer had discussed, that with the drug shortage issue, as we get medications that look different, that may have different concentrations and be packaged differently, there's also that increased risk for error. In addition, provider knowledge is one. And then there's another issue where a familiar medication may be available and a provider may be receiving a patient either from a different service or a different institution with a concentration that may not be familiar to them, again, causing medical or medication error. So the goal is to reduce the variance, and that's the objective of the standardization process. In terms of training, anesthesiologists are by far the most frequent physicians that directly administer medications. And we are fortunate in that we work collaboratively with surgeons and other physicians, nurses, nurse anesthetists, pharmacists, not only in the operating room, but also in the GI endoscopy suites, the interventional pulmonology and radiology suites, MRI, proton, and many other clinical settings. And so we are strategically placed to be involved in helping foster this culture of medication safety. So it was discussed earlier that medical errors are the number 3 cause of death. Errors from medications, actually the FDA came up with a number of errors due to medications, not in the perioperative setting, but in the perioperative setting and in the community, is 1.3 million. This is causing harm, not causing death. And while I was on my flight coming over here, I looked up the population of Phoenix. It's 1.6 million. So 80% of Phoenix would have some kind of harm related to medication error annually. From the study, published studies, the most frequently quoted article is the one that states that there are medication errors that occur for every 1 in 20 administrations. Not that this number creates harm, but this number has been observed. And understandably, the observed rates are more frequently reported than the self-reported rates. And again, as Julie had brought up, there are certain issues where some providers may feel compelled to report an issue where an overdose of rocuronium was given and Sugemidex was given, and others may not. And so in terms of types of error, there are 4 major types. There's incorrect dosing, substitution, which Dr. Pian Smith described very eloquently in her story, where Pitocin was given inadvertently for phenylephrine. There are contraindicated drug administrations, whether a patient has a drug allergy or an underlying medical condition which is contraindicated for a particular drug. And then lastly, issues of timing. Again, the Pitocin example could be used in this situation as well, where it was actually intended to be given postpartum and not prepartum in that situation. And of the 4 types of error, the most frequent is the incorrect dosing. And so the thought is by decreasing that variance with concentration is one way to decrease the incidence of incorrect dosing. In terms of safety, there's a core set of actions that we've determined that would help decrease this issue. And it's not as though it's one particular concentration per drug, but to get a consensus of a few concentrations, and again, dividing this between the adult and pediatric populations, what's given in a bolus dose and what's given in as an infusion, and to, again, reduce the variance in concentration in an effort to decrease medication errors. So we formed the ASA under the committee, the Quality Management and Data Administration Committee formed a medication safety work group, which I lead, and the group consists of QMDA members from other ASA committees such as patient safety, pediatrics, critical care. We've also utilized our partners that are working on the ASHP Standardized for Safety programs. There are several ASA members that served as liaisons for the Step 1 adult infusion process and that currently serve on the Step 2 pediatric infusion process that are also part of the work group. We also engage leaders in terms of the literature in this process as well. We have looked at the literature. We've looked at the close claims studies, published information, and have come up with which medications, form the majority of medication errors in relation to concentration. And we'll discuss that in a moment. But this is really a team effort. How many of you here at your institution, if you are a pharmacist, nurse anesthetist, anesthesiologist, meet with that core group on a regular basis? Raise your hand if you do. Hi, so we can all see you. Okay, great. So at least have half or so in the room. At our institution, we actually have a pharmacy anesthesia work group that actually incorporates pharmacy technicians, anesthesia technicians, nurse anesthetists, anesthesiologists, and pharmacists. And we meet twice a month, focused on many issues, concentrations being one of them as well. Within your facilities, it's important to have these type of relationships. And in terms of drug libraries, within an institution, there may be more than one pump. And so making sure that those concentrations within your institution themselves between the pumps are consistent is something else to focus on. And it's important to balance both the idea of reducing patient harm with what works well and efficiently for process flow, always keeping patient safety in the forefront. So these are the top 10 medications that the group believes should be standardized, first locally at the institutional level, and then hopefully we hope to make this something that is done at a national level. We believe it's important to engage all partners involved. Being at a conference like this where there's so many stakeholders, both from the manufacturer point to the point of administration of the patient, is really enlightening, and I'm really encouraged by being able to develop action items tomorrow as we move forward with this conference. And so I'm just going to briefly discuss each medication, and just kind of, since we have a nice diverse group in the audience, I do want to do this by show of hands. So how many of you, either yourself or at your institution, has heard of a medication overdose within the perioperative setting due to insulin? Hi, raise your hands high. Yes. So commonly, unfortunately, this continues to occur. And so the group believes that, by having a standardized concentration, and these are for medications that are given intravenously, that we've come up with these numbers. The second is epinephrine. When we looked at the closed claim studies, the highest amount of deaths actually were due in terms of medication administration relating to incorrect dose was with epinephrine. Norepinephrine is another drug that we believe should be included in the list, and phenylephrine, which has been discussed more than twice today at the conference. I was encouraged by the award recipient mentioning today that they no longer had phenylephrine vials in the trays anymore because of this issue, and I think that's something that nationally we need to all recognize and accept. Heparin, which is also mentioned this afternoon, again, the overdose of heparin is something that continues to occur, and there needs to be standardization in terms of concentration for heparin. Ketamine as well. This is a medication that providers may not be, it was popular at one time, and then it fell out of favor for a period of time, and that's more popular again, that may not be familiar with. And so having this medication at a standardized concentration. Dexmedetomidine is another one. This is actually very interesting because other medications, when given via infusion, are given typically micrograms per kilogram per minute. And if you look at your pump at your institution, most dexmedetomidine infusions are set at mics per kilogram per hour. And that creates another avenue for medication error to occur. Hydromorphone, lidocaine, and remifentanil. And it's interesting, the concept of drug shortages was brought up earlier today. And of the list that was flashed, 8 of the 10 drugs on this list are also on the medication shortage list. So something to keep in mind. So I think this even, really reiterates the need to have these medications standardized, especially given this day where drug shortages are so common and frequent. So in terms of medication standardization efforts, one thing to consider as these efforts also need to be balanced in terms of avoiding limiting the supply of current medications and further contributing to drug shortages. And so items to consider are, this has been discussed earlier today as well, are pharmaceutical company consolidations. One of the comments made earlier today was the importance of having several lines of productions for medications so that when a shortage occurs, there are alternatives that we all can use to take care of our patients. Looking at vulnerable supply chains and really engaging partners in that process as well, increasing transparency as far as that concept. And then also the key supply drugs being limited to a single manufacturer. We need to look at that issue and relying on more than a single production facility for those of you that administer hyperbaric bupivacaine, or for all of us that had the IV fluid issues earlier. It's interesting that one factor, whether it is related to a weather-related issue or production issue, can really create significant issues for us to take care of our patients. So at this time, I want to thank you for your time, and we'll entertain any questions.
Thank you, Elizabeth. Our next speaker is Deb Pascoe, and I've had the pleasure of working with Deb over the years. She, in terms of standardization, was at the University of Michigan, where she led the effort to standardize the pediatric oral medications. And now with ASHP, she was able to get a grant from the FDA to create this ASHP standardization for safety projects. So Deb, welcome, and look forward to another discussion on this real important standardization. By the way, we actually did a standardization project in San Diego. I think we were the first. It was probably 15 years ago when the smart pumps were first coming out. And we had about 12 San Diego hospitals. We created a standardization of the concentrations and the dosing units. And then we looked at it, and the hospitals really adopted this across the community. And then a few years later, we looked at it, and there was a lot of slippage. And so we tried to figure out why was there slippage, and almost all of it was anesthesia demanding different concentrations than what everybody agreed to. So anyway, Deb, welcome.
Thank you. So Dr. Brown, I am the walker talker that he mentioned earlier. Whoops, is this on? There we go. Okay. So a couple things before I actually get started. So as a previously mentioned, I'm the Senior Director of Medication Safety and Quality at ASHP. How I got medication safety is I actually started 7 years in the pediatric intensive care unit back at Michigan and during my tenure there. And when you combine really sick children with complex medications, unfortunately, bad things happen sometimes. We know this. And it started me down this pathway that has taken many twists and turns. And I sometimes look at my career and just kind of say, how did I get here kind of phenomenon. But I want to also just give a little bit different perspective of I am also a patient. I have Ehlers-Danlos, the classic hypermobility type. So when we talk about the OR, there are several things that actually make me a little nervous from a patient perspective. That patient is me sometimes. So what I heard this morning from a whole slew of really smart physicians was so no deaths and no SIBO, because I'm a female. Talk to Darlene. Definitely no nitrous, like that is not coming in my OR. It's gonna be outside somewhere. I also need to feed my mitochondria, so that was a really good point. So I think I'm gonna be having the discussion if I need a little dextrose, especially if I'm NPO. But so my list got a little bit longer of what I might think of when I go into those operating rooms. So just a little bit different perspective. So standardized for safety. As we talked about, this has been started on many fronts across the nation. Tim's right, it actually started in San Diego. We used many of their concepts as a base to start this project, so we didn't reinvent the wheel. And this is our logo that we use. It has several different things actually on it that you can see here of IVs, syringes, but we also have different transportations. Why do we have that? Because we put patients in ambulances and helicopters every second of every day and transport them all over our country and sometimes internationally. It would be really nice if we had an infant that went from Minnesota to Michigan that was on the same concentration of alprostadil. So as soon as we got there, we weren't furiously making infusions, taking them down, taking tubing, throwing them away. The pharmacy's making more. Every time we do those steps, we have a chance to make an error. We have several partners in these, but I want to call out 3 of them. One would be AMI, the Medical Instrumentation Group, of course, ISMP, and then PPAG. I'm going to quickly go through some of these. Whoops. And so why standardize? We just heard from Elizabeth several reasons of why we should do that. And I really sense kind of a really good presence in this room that you all want to do something. As you've talked at the microphones this morning, that you really want to make a difference. And at lunch, Dr. Goodale said to me, I'm hoping that there's something that we can make an impact. This is a project that you can make an impact. Every single person in this room can do something. Why are we doing it? We're doing it because it's the best thing for our patients. We're not doing it because Joint Commission is breathing down your neck. We're not doing it because CMS might not reimburse you. We're doing it because it's the right thing to do for the patient. We also help with manufacturing. So can we streamline some of our manufacturing lines to where they don't have to make 58 different concentrations of norepinephrine? Maybe they make 3. And by the way, just so you know, as a country, we order 58 different concentrations of norepinephrine. So how does that impact our administration safety? We can then have a little bit bigger inventory. We can give them longer stabilities. So that helps where we can actually have something manufactured instead of making something on the fly in the OR. And then we also have what is called ready-to-use packaging or ready-to-administer. That means that you're essentially going to take it out of a bag or out of your crash cart or out of your anesthesia box, and you are not going to manipulate it any further except just attach the line, program the pump, and go. No more diluting, no more mixing. I'm going to skip over this. I do have training in lean. I will tell you I drank the Kool-Aid at Michigan very early. So I'm not going to go into this, but just to say I'm really into high reliability. And high reliability lends itself to doing something the same way every time. That you in the OR, 30 years experience, you may know how to quickly do that phenylephrine infusion off the top of your head. But guess what? Your first year resident that's coming in that OR, maybe not so much. How many ORs are you overseeing that day? Maybe it's 3 or 4 at a time. I'm going to skip over that too. Basically, what is the problem at this point? The problem is that we have not been able to come together as a nation to agree on standardized concentrations before now. So 2018 is the year that we are making this happen. We've already done the list for the adult continuous infusions. We are working on kind of phase 2 of that. We also met in May and June and did the pediatric continuous infusions, and we also got through PCAs and epidurals. The later, those 2 lists, the peds and the PCAs and epidurals, those will be coming out probably within the next 3 weeks. We'll post those and we'll open them up for comments. But we want to make sure, why have we had so many problems at this point? So Tim, you mentioned, San Diego, that was a long time ago. And why are we still struggling at this point? We're struggling because a lot of times I hear, we've always done it this way. Dr. Trumper at Michigan, this is the U of M way, right? And Deb and I, we don't argue with Dr. Trumper. But we do sometimes try to make an argument of, is there a really good reason that we're doing this? If there is, then let's take a step back, have a good conversation about it, talk about it as an interprofessional group, pharmacists, physicians, nurses, and how do we move how do we move forward with that? Weight categories. Down here. This is a really tricky one because when we started doing this, and as someone that came from the PICU, we would have 16-year-old, 100-kilo football players in a bed next to a 3-kilo congenital heart kid. And it became very evident at some point, and I would come in for morning rounds, and let's say the 16-year-old, I would say, how much morphine are you infusing? And they'd say, oh, I'm up to 150 mics per kilo per hour. Okay, so you're at 15 milligrams an hour. Is that what you're telling me? And then they look at me and go, we can't give them that much. And I'm like, well, too late for that. That was a decision made by the overnight team. But so this point about how we talk and the dosing unit matters. At what point do we say, you really need to switch into an adult thinking flat dose mentality? That's really difficult. So we decided to actually draw a line in the sand. I am not saying that this line is perfect. If people want to get up and debate or throw candy at me, I'm perfectly happy, good with that. But some argue 40 maybe, 40 kilos, but definitely by 50 kilos. We should really be out of the per kilo and talking more about flat doses. Now, there are some nuances to that. I will definitely get to that. This is the current status of our project. We have a lot in process right now, but we will get there. Drug shortages took a little bit of my time, if you can imagine that, where we were finding an interim person with my organization, but we're moving forward. So I'm really excited to share some of the lists with you, and that will be coming out. Intermittent medications, this one I actually thought we were going to do first. And lo and behold, there is a company, they're called Bainbridge Health. They're doing some pump data analytics. And what they are showing me is just fascinating. And Sean threw up a graph in front of me, some of their customers. And the top 5 drugs that they were firing alerts on, 3 of the 5 were straight drug intermittent medications. And I looked at it, I'm like, Sean, Ketorolac's your third one, Ketorolac, 15 milligrams per ml, straight out of the vial, what's the problem? And he looks at me and then he shows me another graph. The next graph showed it was firing a concentration alert, that it was programmed in the pump as 15 milligrams per ml. Guess what was happening? If you take 1 cc of Ketorolac and dilute it in a 5 ml flush, you get 3.33 milligrams per ml. They wanted 3 milligrams per ml, not giving them the right thing. So our nurses, and maybe some of you in the OR, were diluting because they wanted something a little bit more dilute, that maybe we swung the wrong way, and maybe we have things too concentrated. So that brings me to guiding principles. We always want the patient in the middle, obviously, but now that we're in drug shortages, we have to think about things like operational concerns, I don't want to waste, but then I have things like 797 and the CDC that tells me only 1 vial, 1 patient kind of thing. So we need to think about all those things. quickly go through. I put all these slides in here not because I was going to talk about all of them, but just so you would have them. This is the first list. So this is version 1.01, as I call it. Sorry, Apple. But it has 32 drugs. So in addition to the 10 that Elizabeth just showed you, we decided to go for 32. Many of them are high risk, but this is our list for now. I can tell you that the pediatric list that we will be coming out with, 46. They actually added more to that, and they did a fantastic job for that. So what have been our challenges and questions along the way? Pardon me as I just check my time. So just to kind of conclude here, what were some of the considerations that we had? Size of the patient. What was their access? So there are some drugs that we have more than one concentration listed. That could be for peripheral and central. It could be that you needed a low concentration versus a higher concentration. It could be how you're giving it. The dosing units, we took this one on, I will tell you, and talked about mics per kilo per minute versus mics per minute versus mics per kilo per hour versus milligrams per kilo per hour. It's all over the place. So those were some of the things that we had to think about. And I will tell you that we definitely listened to the OR about your paralytics. If you're giving them straight drug in the OR, there is no reason that we should be further diluting them when they get to the critical care unit. Like, that just doesn't make good sense. If we make errors in the pharmacy compounding paralytics, that could really harm someone. So my last point here about dosing units, how you talk matters. So propofol, for instance, it's kind of a drug we've thrown around today. By the way, huge lover of propofol. Like, when that came about, it was like, oh, I wake up, I'm not nauseated, like, this is heaven. So anyways, and as a side, so propofol, how many talk about in mics per kilo per minute? Anybody? Okay. Milligrams per kilo per hour? A few of you. Milligrams per hour? Nobody. Any of you talk about it in mils per hour? Thank God. But I can tell you that I've heard throughout my clinical career, I've heard propofol described in all of those terms. The one time I was in the SICU at Michigan, and on one side of the SICU, considered SICU North, they talked about norepinephrine in mics per minute. On the south side of SICU, I heard it in mics per kilo per minute. I am in the same adult unit, but guess what? The North team had anesthesiologists rounding on their patients for the day, and the South team did not. They had the surgical group. So just in that time frame of what we were talking about, so, it's bad enough that we abbreviate the drugs. So like DUX, for instance. DUX to everybody in this room right now is dexmedetomidine. If I get on rounds, the HEMOC person thinks I'm talking about dexamethasone. So it's one of those things, how you talk matters. How you talk matters. It's drug. It's full name of the drug. It's the concentration. It's the concentration units. Why is it that my dopamine is in mics per kilo per minute, but my pharmacy sends a label out that says milligrams per mil? Whoa, like, what happened there? And on top of that, then what does my pump say? Because my pump may say something different, and my pump may say something different than what my MIR even says. So, to leave you with that thought, this is something, though, that we can do, we are doing. I need all of you to help me with this, that you are champions. You know how to do this, you know how to talk to your colleagues, and more importantly, please do it for our patients. Thanks.
Okay, we're going to have the panel, and our two Pharmedia and Fresenius Kabi folks would like for you to rejoin us because we didn't have a chance to get any input from you, if they're here. Here they come. Do we have enough chairs?
Nobody else wants to.
Here you go. Be careful where you sit. So, you guys have a seat. Okay.
Kevin, I think you deserve it.
This better be a long question
Yeah.
or need a long answer.
Well, it's got a story in it, so maybe it'll be entertaining. I don't know. Thanks a lot. Great session. Steve Barker again. In my previous life, before anesthesiology, I was an aeronautical engineer and a pilot, and so I believe very much in checklists, and I'm glad to hear them mentioned. And my checklist for giving or for ordering medications, and I realize we in anesthesia, we're usually pushing the plunger, right? We're not so much writing the orders, and partly because of that, I think we get rusty at it, and we forget the checklist, which is DDIRT. Drug, dose, route, time. And the thing I didn't hear much about today, I saw it on one of your slides though, is route. And I want to hear your thoughts. Here's a quick story, 30 seconds. Trauma patient in the ICU that we're taking care of. He's badly injured but expected to survive. He's on tube feedings. He's got pancreatic insufficiency from his trauma, and so he's getting a drug called Viocase down his feeding tube. Viocase is a mixture of pancreatic enzymes, not something that we use every day. The order was written, Viocase 1 gram and 20 mLs NS, normal saline, period, end of order. The nurse took the order down, mixed the drug, and gave it in his IV. It took him 8 hours to die, a really horrible death that was completely preventable, and that story has stuck with me the rest of my life. I hope it'll stick with you. The importance of the right route, because we know the route automatically doesn't mean that the person giving the drug knows the route. So what do you suggest for ensuring that never happens? That should be a never event.
I think one of the most distressing wrong routes that I know of is the chemotherapy in children or even now in adults with brain tumors. So very common to give methotrexate intrathecally and vincristine IV.
Yeah.
The first wrong route with vincristine given intrathecally, and understand it is a detergent. It is an incredibly slow, painful dissolution of the spinal cord and the brain. Patients usually take about 4 to 5 days to die, and they know what's happening.
Yep.
After the first description in 1969, there have been at least 143 doses like that. MD Anderson in the early 70s made a rule that methotrexate came in a syringe and the vincristine came in a bag. ISMP has that rule in 2018. It took us that long to adopt an incredibly safe way to prevent the wrong routes. We do now, there is an ISO, there is an international standards. They are making, if it's for small bore connectors, and the connector, ubiquity of the lure lock is what the problem is. So there will be, they have released the NFIT, which is for enteral. They've released the NearFit, which is neuraxial. InFit is green, neuraxial is yellow. You can't put any of them together with a lure lock. They have done now for pressure, and the other routes are coming. California, I think, is anybody here from California? Is it still delayed? Yeah.
It's been 3 times, I think.
Yeah, but so it is coming, but we have known how to prevent many of these. We just haven't done it. And why don't we have, Kevin has told us, why is this that we just don't do it?
Right.
Ron, I think when we were at ASHP a couple weeks ago, Mike said there were 2 more. One was an endotracheal tube where they blew up the trach with hooked an IV into it with a pump.
Into the cup.
Into the cup.
No harm, no foul.
And the second one was another one of the epidural given as an IV, right?
Yeah.
Which is there's a very easy solution to that one up above, is you just don't use a spike on the set. You put in a bag spike that's a needle-free valve and have a set that only has a male lure on it, and you'll never have that problem. I don't even know that those exist.
But the other way around, we had a patient who got 10 cc's of my favorite drug, thiopental, into his epidural catheter. He actually lived to tell about it.
And they're actually, in addition
Thank
to
you.
the InFit and the NerFit, they're working on syringes too, so that the syringes are not,
It's
yeah, it's the whole thing. It's the entire, it's the syringe and the tubing, everything, so that it is not interchangeable
And
anymore.
the CAD cassette is different, right?
Okay, next question.
Andy Bowdle, Seattle. I have a question about standardization. We have very strongly embraced standardization in our hospital system, I think. Well, I know that all of the anesthesia drugs, at least, concentrations are standardized across our system. I was interested in and a little bit surprised to see the recommendation about using flat infusion concentration or flat infusion dosing for greater than 50 kilos. I'm a cardiac anesthesiologist, and of course, I'm running 12 infusions, constantly during my cases, and they're all in mics per kilo per minute. So, and I realize that there's a long and elaborate argument over the years in pharmacology about whether dosing in adults should be weight-based or not for a whole lot of drugs. But I'm just curious if the idea of administering that long list of drugs at flat dosing for greater than 50 kilos is evidence-based, or whether that's just a philosophy.
So I should have clarified a little bit. On that list, we chose the vasopressors to leave in per kilo because of consistency, and that it kind of calls those out versus if I'm running a midazolam infusion. So we actually chose, all the pressors on there are in a per kilo. It's been highly debated. There have been articles that have come out that said there's no difference. Me being a pharmacist, I basically said, those patients are also fluid overloaded many times, and that you have to take into account the majority of those, especially vasopressors, are water-soluble drugs that we need to account for if the patient is significantly fluid overload of actually they probably need more medication. So for the vasopressors, we chose to take a stance to put it to actually save on a per kilo, but the other ones, such as the analgesics and a couple of the other groupings, we then said, like milligrams per hour. So thank you for asking that question and letting me clarify that.
Okay, great, I understand. Thanks very much.
We have a lot of questions and not much time, so we'll try to make these short answers.
Okay, actually,
Julie.
this is more of a comment and a bit of a question. I'm Gary Haynes from Tulane in New Orleans. And I'd just like to thank you, because there are a lot of great comments in this presentation. And I kind of heard a couple of themes come through. One of a lot of great opportunities, things you've identified that we can do, and also a certain amount of frustration. As you say, why haven't we done this by now? It's been years. And I'm thinking, wow, how does this fit with the hospital world that I know? Because I've worked with a number in recent years, and I see in the United States, what's going on is a rapid consolidation of hospitals and hospital systems that are getting larger and more difficult to deal with. And the ones that are left behind, not part of some bigger enterprise, are becomes smaller and smaller with fewer and fewer resources. And what I think also comes through is that a lot of what you talk about is based on information technology, which is the EHR and everything else that goes along with it. So what I'm curious to know, or just for anyone in the audience, how do we get the message to the leadership of these large organizations, which is the route by which most of our care is delivered, to bring these different ideas together? Because from the hospital CEO and CFO perspective, they're thinking about one thing: cutting costs today and nothing more. But how do we get a business argument to them that gets them aligned with our clinical interests? I know it's a difficult question, but again, as much of a comment as much as anything, but I'm curious to know what you might suggest to the hospital CEO.
So we know that one medication error can cost between
nothing, or roughly $500,000 to $6 million, depending on the error. And I think that if you look at the cost savings, the implementation versus the cost of one medication error if we make it, and then also the facility having that come out, we have to talk to the people up in the C-suite in the language that they understand. They understand length of stay, dollar signs, and how it's going to cost them. And so I think we have to change our conversation and come out from behind the OR doors and advocate for our patients and advocate for the standardization and access to these supplies, because in the end, we are decreasing cost and improving the care of the patient.
She doesn't have as much gray hair as I do. I have not met a CFO that can hear, if you spend $3 million on this Safer Sleep or Codonics or, the Becton Dickinson, you're going to save medication errors, because they truly believe they will not happen. And other gray hairs are nodding with me because they've been to the CFO.
So, and just, sorry, Tim, quickly, because I've been a hospital administrator and been with that C-suite, I have put a patient's picture up, and I have taken my CFO to the bedside of an ECMO patient. You do what you need to do to get through to them.
The only thing that works is CMS. That's it. So if you can convince CMS to put that in the regs, it'll happen.
Did everyone hear that? Ron says the only thing that works is CMS.
Yeah, and
Okay, next question.
So thank you for the fine presentations, as all of them have been. I was particularly interested in the Standardized for Safety project. I hadn't heard of that before. It's ASHP. It sounds like you're totally dealing with infusions, which is a very important field. What I do as anesthesiologist is probably weighted more heavily towards single unit injection doses. And I just wonder if the ASHP is any interest in getting any recommendations nationally for that, or if maybe the APSF does, or the ASA. Because if we had a weight of a larger society behind that, maybe we'd get it done for the manufacturer. So that's just my comment.
Yep, so the last stage will be the IV intermittent medications, and these will be the single dose that we most likely put in syringes, et cetera.
If I can help you move that up, let me know what I can do.
If we could clone myself, that'd be really good. But no, we actually saved it to be the last stage of it because of some of the data that we're currently seeing that's probably going to guide those practice changes. I want that to be very data rich, so that's the delay.
Paul Preston, Northern California.
I'd like to quickly respond as well. So there are ASA members on the Standardized for Safety groups as well. And so just want to let you all know that, yes, ASA is working with ASHP in that process, but we're also, as I had listed those 10 medications, we'll also come up with a list as well, incorporating both single IV bolus as well as infusion concentrations, both for the adults and the pediatric populations.
Paul Preston, Northern California, Kaiser. One strategy, we have a very successful high alert medication program. It doesn't help us in the OR because of the reasons we've been talking about all day. It was founded on an intrathecal vincristine and a pediatric pressor error in an ICU. It wouldn't have gotten started without those two absolute inexplicable catastrophes. You sort of have to be ready with your chief C-suite to say this is how we need to move in the next direction now. And sometimes it takes the tragedies, but it has been successful. It has been sustained. Quick comment on the standardization of concentration. Our best luck has been when it's built into the order set. Are you guys reaching up to Epic and the other electronic? I mean, it'll take 2 more years for us to work it through the rest of the system.
We have reached out to Epic and Cerner. I can just say that we are in active and ongoing conversations with them about the project.
Get them from both sides.
I'm trying.
Well, thank you all for your comments. Couple of my own. One, when you talk about dosing units and concentration units, I'm glad you clarified that because there's some differences in how that could be perceived. Steve's comments about route are very important. But you also mentioned ready-to-use syringes and other things that are in the future for the standardization. So I would like to ask the Fresenius person from a corporate, we've been sitting here talking about shortages, drug shortages, we're talking about cost, we're talking about suppliers. From a manufacturing perspective, when you hear about standardizing concentration or creating syringe delivery systems, what is most effective from your perspective for safety as well as cost?
Well, I have to I have to be honest to say I can't talk about cost in my role because I'm head of quality for Fresenius Kabi North America, but I do have some colleagues here that will be happy to discuss that with you individually. So I can't do that. To answer abroad, let's address the drug shortages. I was sitting there, and it bothers me when I hear blanket statements about drug shortages because there are so many of us in industry who are doing different things. FDA does say that it's a quality problem throughout industry. And what they really don't disclose is that it's the ever-changing standards that they put upon industry that we have to keep up with. And then they give us maybe a couple of months to meet those new standards. And if you don't, then you see the warning letters and things that come out. So that's something else that we have to keep up with. And it also impacts our entire supply chain, so our API suppliers. Right now, if you have a chance to look at the warning letters that are out there to our API suppliers for data integrity, that has a big impact on the finished product drug manufacturers because now we can't get API or there's a delay. So it's more than just what's happening in our plants, it's also the entire supply chain that we have to look at. We do look at different, and I hope to answer your question, we do look at different different opportunities. You know, right now we're opening up a new 503B compounding center in Canton, and we have made a commitment to the agency that that compounding center will be strictly a GMP center, and we are adhering to all of the GMP regulations in addition to those that are under 503B. That's one of the reasons we haven't launched yet because we are being very strict about that, and we want to keep our commitment so that we can get product out. Dr. Warren was at our company a couple of months ago and giving us ideas for labeling. We take all of that in consideration. Our colleagues that I have here with me today or invited me to come along today, we take that, we give that feedback to our folks in our I&D center, and we have this big project that is being financed from our folks in Germany called Innovate, and one of the things are delivery systems that we're looking into and the changes that we can make there. So there's always something that is evolving that we are looking into based on feedback that we receive from attending conferences like this, and we do take them back. One of the other things, we talked about Diprivan, propofol a lot here, and just to clear that up because we are one of the major suppliers of that drug right now, we do have redundancy within the Fresenius Kabi network. We have 13 manufacturing plants throughout the world that are FDA approved. 2 of those produce Diprivan for the U.S. And in addition to that, we keep a 4-month supply on hand because we know that's one of our major drugs and the things that can happen without it, with what the industry experienced several years ago. So we are looking to even increase that redundancy in a lot of other products that are deemed critical based on feedback that we receive here and that our sales team gets. So it's something that is an ongoing effort that we are doing. So it's not, so when I hear blanket statements like that, I want to raise my hand and say, wait, we actually do tell the FDA what's going on when we have a manufacturing delay. I too speak to them, to our drug shortage team, FDA's drug shortage team on a daily basis, and we have a bi-weekly meeting. And we are very transparent. The problem, I think that what the others are hearing, based on our telling them this information, it is confidential. So they can't tell ASHP why Fresenius is not manufacturing this particular product. It's a confidential situation that we're in. We're telling them, but they can't disclose that information any further. And I wanted to confirm that, so I called them before I came here to make sure that is what is happening. So we are disclosing that information. I can't speak to everyone in industry, but I do work with a lot of my colleagues within industry, and we do disclose the information. They just can't share it with you, and we do try to work with them to prevent drug shortages.
If I can just add on as well. So as a result of the Standardized for Safety initiative, there have been 6 major manufacturers that have reached out to us asking about the list, when things are coming out, et cetera. I can't leak out confidential information until it's publicly known. But once the lists come out, it's kind of like, have at it. Whoever wants to make it, whoever gets to the finish line first. I will say Fresenius Kabi was one within that 6. So we do have partners with us. And the FDA, actually, that's got attention of Commissioner Gottlieb. So if I didn't mention, Standardized for Safety initiative is a grant from the FDA, and they've worked very closely with us on that project. Tim had handed me a note about, if I can just talk about meds being shipped across state lines a little bit. This one's tricky. I'll try to be precise. It depends if it comes from a manufacturer or if it comes from a 503B compounding. There are certain rules about drugs being shipped across state lines if it is a batch process and you are shipping from a 503B versus a manufacturer. There's a lot of rules and regulations, so just, I would say, check with your pharmacies about if they are using certain products with the 503Bs and what state regulatory laws may apply based upon the state that you're in. Because right now that's up for a huge discussion with the FDA. Yeah, and it limits the supply. So I live in the DMV area, so DC, Maryland, Virginia. There are times where we literally can't share drug even within that region because of certain state regulations.
Okay. Mark, did you have another question?
Just stay there for a second, yeah. Great. Thank you, Tim. So number one, we'll be taking a break in about 2 minutes, and we'll come back at 10 after 3. We'll be awful close to being done on time. Not quite, we'll be awfully close. I think Melanie mentioned I had the opportunity a couple months ago to visit actually our 2 sponsors, both Fresenius Kabi and Pharmedion, to learn more about this topic as we start to set this conference up. Very impressed with all the effort they go through. They're opening new plants, both organizations, I believe, and they were very receptive to a whole variety of potential opportunities that all the different speakers have provided to me, so I was able to share some of those with them early on. And so I think we've got partners in this, and we just need to work awfully closely with them. We've got great efforts going on in a variety of spots, and the question is, how do we pull that together? The AANA is doing terrific things with this. The ASA is doing terrific things with this. We've got ASHP. We've got all the different groups are doing things. And then just how do we make sure it's coordinated? How do we advocate together for these things? Because separately, not so great. But if we can come up with a game plan where we all agree on the things to advocate for, I think that's probably going to be the most effective thing we can do to get the ball across the goal line. And it won't be every goal line, and it won't be every ball. But if we just make progress instead of sitting back and not let it happen. That's my speech. I apologize. But anyhow, guys, we're going to take a break. Fantastic talks. We'll be back at 10 after.